Good morning. Well, no, good afternoon. Well, good morning to some of you, I guess. And welcome to the Research Connect series. I'm Hans Forster, and I will be facilitating today's webinar. And just sort of as a background, I was a researcher by trade in an earlier life, but now a patient partner, or a PFD partner, as CDTRP calls us. But given this background, I focus on research, particularly in nephrology and transplantation. I've been on the team of a number of published studies, and also serve as co-chair of CNTN, the Canadian Nephrology Trials Network, their executive committee, and hold a similar position with the executive of the Patient Governance Circle of CanSolve. You may also see me pop up on several other committees, panels, and working groups dealing with kidneys and or transplants. So that's who you're looking at here. First, I would like to acknowledge that the CDTRP is hosted by the University of Alberta, which is located in the Treaty 6 territory, a traditional gathering place for diverse Indigenous peoples, including the Cree, Blackfoot, Métis, Lakota Sioux, Iroquois, Dene, Ojibwe, Saulteaux, Anishinaabe, Inuit, and many others, whose histories, languages, and cultures continue to influence our vibrant community and across, I guess, most of the nation. Personally, I am from Kingston, Ontario, which is in the Cataraqui region, and the traditional home of the Anishinaabe, Anishinaabe, and Huron-Wendat peoples. And I encourage you all to write your land acknowledgement in the chat box. We would also like to acknowledge Astellas, Takeda, and AstraZeneca, without whose generous support we could not host these sessions. The CDTP also relies on help of our community, so your gift ensures that we can focus on delivering our mission of supporting excellence in donation and transplantation research. There will be a link in the chat box for those that are interested. But before we dive into the main content of today's agenda, I will pass it over to Erica for some general CTRP notes. Erica?
Yes. Hi, thank you, Hans. I have two announcements today. The first announcement is going to be a save the date. This year's Patient, Family, and Donor Research Forum will be held virtually on Thursday, June 8th and 9th. Registration is free, and it can be done through our website. The link to register will be shared in the chat box. And if you have any questions, please feel free to email Manuel or myself. The second announcement is a reminder call. For anybody who is interested in applying to the CDTRP Innovation Grant Competition, consider submitting your application soon, since the deadline is April 12th. Thank you.
Okay, before I introduce the speakers, I too have a few housekeeping notes. Today's session is being recorded and will be posted on the CDTRP website and YouTube channels, so you can watch yourself later. During the presentation, we encourage that you keep your cameras on, but your microphones off. And if you have any questions or comments, you can raise your hand with the raise hand button, which you will find across the bottom of the screen. So I'm pleased to introduce our presenters today, Dr. Michaël Chassé, and his student, Dr. Nicolas Sauthier. Dr. Chassé is care at the center, in intensive care at the Centre hospitalier de l'Université de Montréal, and an associate professor in the Department of Medicine and the School of Public Health at the Université de Montreal. He holds a PhD in epidemiology from the University of Ottawa. He is also Associate Director of Data Science at the CHUM Research Centre for the integration of analysis and medical data, also known as CITADEL, which brings together scientists and professionals specialized in health data science, biostatistics, bioinformatics, and machine learning. Really impressive. His main research interests focus on improving traditional epidemiological research methods using new technologies such as machine learning and innovative clinical trials, particularly in intensive care areas such as organ donation and death determination, organ transplantation, and blood transfusions. Dr. Sauthier began his education with a bachelor's degree in biomedical engineering at Polytechnique Montreal. Afterwards, he completed his medical training and residency in anesthesiology and critical care at the University of Montreal. The combination of technology and health has always fascinated him, especially since the valorization of massive databases and their use to solve concrete clinical problems. This motivated him to do, in parallel with his residency, a master's degree in biomedical sciences, option computational medicine under Dr. Michaël Chassé, and this presentation constitutes the main results of his master's degree. We're all very excited about your presentation, and I will handle it over to you, Dr. Sauthier.
Thank you, thank you for the introduction and for the opportunity to present. While Nicolas shares his screen, just a little bit of context. So this project has been in progress since maybe 2019, and I'm very happy to present the results today because it has been funded by the CDTRP, one of the grants that the CDTRP kindly offers each year, and Nicolas was one of the students who worked on this program. So just a little caution here. Some of the work you'll see will involve automatic screening of potential organ donors and novel technologies related to AI. But please focus more on the science and the feasibility of the project and not on the applicability at the bedside, because we're not there yet. So what we present today are preliminary results of feasibility of such algorithms, but we have a complete other program that looks at acceptability of these kind of technologies and how we could implement this at the bedside and so on. But today we will really focus on, is it doable at all using routinely collected data. So Nicolas will take over the microphone, and I will just remain here if there are questions at the end. And I will also monitor the chat and follow the questions to help in answering. So Nicolas.
Hi, thank you, Dr. Chassé. Thank you, everyone, for inviting me. So as Dr. Chassé said, I will be presenting basically my master's research. So I have no conflict of interest, except as Dr. Chassé said, I was quite lucky to receive a grant, an innovative research grant from the CDTRP. And also, as Dr. Chassé said, it's not been applied in the real world to make decision. It's still in research mode, although quite advanced, but still in the research mode. And there are huge domains that needs to be explored with multiple people, including patient, to discuss the applicability and the issue of that. So the problem, as well, most, if not all of you know, there is an attrition between each step of the way from the population going to a utilized donor. And one of the critical steps in that process is going from potential donors, being recognized and being referred to one organ donation organization, such as Transplant Quebec in Quebec. Our project was to address that critical step, because if you can improve the identification and referral of those potential organ donors, you can improve the number of utilized donors without changing anything in the rest of the process. And based on retrospective data from almost all over the world, we can know that we may be missing between 30 to 50% of those potential organ donors. It all depends on the methodology that we used, where the article was done, but it's quite known that we miss quite a bit of organ donors. And the question we were asking ourselves is, what if we could automatically, with minimal human intervention, screen for those potential organ donors? By automatically, we mean that our approach was to have an algorithm that would screen without the need for someone in each hospital to fill a form, to ask a system if it's a potential organ donors, but like a constant overlook and screening of all the organ donors. To do that, we need, as all machine learning project, we need data. We need a lot of data. And the big picture we had is we have a lot of data in healthcare. Not all of the data is usable, but we have a lot of them. What if we could use those data, combine them in some way in an algorithm of some form, and that algorithm could raise a flag, whatever the form of the flag, and signal a clinical team that the patient may be a potential organ donor that would need further investigation, but to do the screening and in an automatic part. We have a lot of data, as I said. Most of the data is, however, not usable in most of the hospitals in Quebec. We do not have a proper electronic medical record. So part of the data is digital, but part of it is still handwritten in file. So we focused our interest mostly on the lab because it's an unbiased and digital form of data. We used most of the data we would like to have used is in the charts, but it's, as I said, not usable. We have a bit of data, as I'll explain, that we use in that part. Radiology is extremely useful as a form of data, but also extremely hard to use, because you can use the radiology report, but to do so, first you need to parse through text, and then you need to wait for a radiologist to read the image and then to type it. You can use the raw image, as I'll explain a bit later, but it's hard, and it's a project in and of itself to analyze with machine learning an image, a medical image. You have vitals, but vitals are not universally digital, and almost everywhere they're not stored. So you cannot develop a retrospective data set of that. And it's quite a high quantity of information, because vitals are at the second or somewhere in that time frame, but labs are once a day. So you have a different time frame here. Medication, very useful also, but unfortunately, we do not have access to pharmacy database, and the CITADEL Quebec, which is a file that's for all patients in Quebec, is not accessible for research. And microbiology and pathology is digital, but may not be that useful as a first sort of information. So we focused our effort in that step, but all of it is quite interesting. So we are in around the second phase of the development, as Dr. Chassé said. So the first part is, of course, developing and testing the algorithm, which is retrospective. We did a bit of external validation using coronary care unit. I'll speak about it a bit later. And we're about to embark in prospective validation, which is still in research mode. It will allow us to test in real world data, test what would be the applicability. Is there any bug in the application on a prospective fashion? And of course, the implementation needs to be addressed, but it's something that needs to be addressed throughout, but needs to be focused on at the end. In each step can give us information to go back and tweak or adjust or improve the algorithm, and there's a circle. So I won't bore you with the detail, but I think a bit of definition and machine learning 101 is quite important to understand this project, but also because it's quite interesting to know for all kinds of projects. First thing, so data in healthcare is among the most difficult data to use because it has a lot of bias, a lot of problem, and I will go through some of them. First of them, is of course privacy, which is necessary, but it is also for research purpose can be hard. You cannot access every hospital, every data, all patient in only Quebec. So if a patient was followed in one hospital, transferred in the CHUM, we did not have access to the past medical history of that patient. Data is not per se integrated. So you have pharmacy database, you have laboratory database, you have imaging database, and they're not standardized and not linked. And on that part, CITADEL with Dr. Chassé and his team did an amazing work of linking all of the small database and the big database in the CHUM with a single identifier for each patient. That it was really the key that allowed us to merge those data and get the data required to do the project. Without that, it's almost impossible. I will skip about how many. Data can have errors. Errors can be, in my database, I had temperature of the patient that was written by a nurse or by a clinician, and I had more often than not error in that type. So a temperature of 376 is of course 37.6, but you have to screen for thousands of patients. You cannot do it by hand, and sometimes it's not arterial blood, it's venous blood, but you cannot know just on the lab. So there are errors in the labs, and you have to do with it. Data can be missing, not missing at random per se, but missing in the sense that someone maybe did not require a coagulation panel, and someone had in the algorithm. You have to input some data about that. So it's missing. You have to input something for someone that did not require a lab, or maybe a lab that's done 3 times a day in one patient is done 3 times a week in another one. So you have to know and to input data in some way or another. Data can be imprecise, meaning that data is always collected for a clinical purpose. So, for example, if a patient takes anticoagulation medicine in pharmacy, you'll know exactly the dosage and the type of anticoagulation. But in the labs, if he has a coagulation panel, the nurse may only have written anticoagulation, yes. So you'll have to do with data that's imprecise, that was not done for research. And when you try to predict something in healthcare, it's always, almost always, difficult prediction, because for maybe life, death, or organ donation in our project, sometimes even a trained clinician cannot do the prediction. So how can even a complex algorithm do better than a clinician? It's almost always difficult to predict. And you have problem in class imbalance, you have problem in bias in the data. State estimation, I'll not speak about that, but multimodal is also one of the biggest problems, because you try to merge data that are sometimes image, sometimes text, sound, signal for the EKG. You have, of course, labs that are purely numerical, but you have categorical data. For example, pharmacy is a categorical data. How do you encode numerically the type of medication that the patient takes? So there are a lot of complexity that makes it interesting, but that's all need to be addressed before you start a project. You have, now speaking about algorithm, you have 2 main family of algorithm. The first one, the most known, is the supervised one, which means that when you train whatever the type, here it's a neural network, but you have whatever the type of algorithm, you'll need to have a database with input known and output known for that input. So you train the algorithm to link between the input and the output. So as a toy object here, you could have an input, which is an image, and you trained it to recognize if it's a painting or a photo, for example. And you'll train it on a known database in order to predict afterward for a known image if it's a painting or not. Can be an image, can be text, sound, whatever you want. Sorry. And the other family of algorithms are called unsupervised. So it's an algorithm. Again, you can put whatever you want here. Here we've got an example of autoencoder, which means you put the unsupervised is you do not know an output for that type of algorithm. So in the autoencoder, sorry, you put at the input and at the output exactly the same information. So the network learns to compress, if we can say, the information to a smaller data size and decompress it without loss. The idea behind that is you can, of course, do a compression, but you can also change an image to numerical data and back to an image with the minimum loss of information. And you can do a very complex network, train that on a database that you do not know the outcome. In our example, could be organ donation. The other thing that's quite useful about that is you can do what we call anomaly detection. Because if you take a database, a huge database, and you know that you do not have the outcome of interest in that database, you train the algorithm on that, and then you expose the same algorithm to something that he did not see before. He would not have known how to deconstruct and reconstruct it, so he will make mistakes in the reconstruction. And that's an information that we can use to track the anomaly, because he is not trained to decode and to recreate it, so he will make mistakes. And the quantity of mistakes can be a marker that we used in our first iteration, as I'll explain. And as it's quite flexible, you can combine both of them. So you can have only the encoder part, so it's transformed in a numerical version, and on that numerical version, you can put a classifier with a train. So we'll arrive, but our main model is of that subtype. And finally, for every project, you need, if you do a supervised algorithm, you need a clean outcome. And our outcome was prediction of potential organ donors. So what is potential organ donors? So we were quite lucky to use a death audit done by our ODO in the CHUM, that with specific criteria of brain injury, mechanical ventilation, and death within a certain time frame after withdrawal of life-supporting therapy. They flagged either local donors, so patients that were detected, referred, and went through the whole process. Patients that were referred but were not eligible, most often because of family refusal, and patients that were not referred, sometimes because of family refusal prior to the referral, sometimes for a reason, but no medical reason, only patient that could have been, well, should, depending on how you talk to, been referred to an organ donation. And we combine that because we have quite a big population in the CHUM of transferred patients that are detected in another hospital, the first determination of brain death done in another hospital, and he's transferred because the hospital doesn't have the capacity for organ retrieval. We combine the two systems to have our outcome, and we had about 400 potential organ donors that spans from the not referred to the transferred in a death, brain death status. So if we continue with the results, so we were quite excited. We embarked on that voyage, and our first model was quite simple, not a lot of lab, not a lot of patient. We did that with one of the data scientists at CITADEL, which is Rima Bouchakri, who helped us throughout the process. But our first approach was, as you can see, with under the diagonal rock curve, which for those who don't know, it's quite bad. And the reconstruction error was did not allow us to do a differentiation between what are the donors and what are the non-donors. You can see that they do quite the same type of error. So we went back to the drawing board and we improved on two sides. We improved the algorithm, of course, but we did quite a lot of improvement in the data set. So we approached the data set in two parts. So first part, we had two static values. The idea behind that was to have the less bias in our network, something that's all hospital, even if you don't have electronic medical records, sorry, even if you're a small hospital, you can have this information. So the first one was, did the patient have a head scan? not even the image, only the fact that he had a head scan. The only one was which reflected a bit of neurological or brain injury. The other one was the service of admission. So the patient in the emergency room is attributed to one service of another, cardiology, neurosurgery, whatever, and it does reflect a bit of the reason of admission. So those two information are always digital in all hospitals throughout Quebec, of course, and probably throughout Canada. And we heavily use the laboratories. So we did an automatic approach. So we use laboratories that were frequent, meaning that at least 10% of the patient had the laboratory. So all laboratories that were present in less than 10% of the patient were excluded, which left us without any surprise, the most frequent laboratory that you use in a standard ICU, which reflects almost all systems of a patient. So we have temperature, we have arterial blood gas, venous blood gas, lactate, blood count, coagulation panel. We have hepatic workout, we have renal workout with urinary analysis. So everything that's quite used in almost all hospitals. And they're unbiased, as I said. We use the same approach, so only an autoencoder with the error of reconstruction. And as you can see, we did improve quite a bit from the other approach, but it was still insufficient because the 2 points that I've put out were the 90% sensitivity and specificity. And with some things as rare as we have here, it's insufficient to have like almost 60% specificity for having 90% sensitivity. You have too much false positive and false negative. So we had to add a bit of specificity to our model, and that was our final approach. So on the left side, we have the neural network model, and we used a comparative model. There's no published model that do what we do, but we decided to use a simple non-temporal model as a sort of a baseline. But in of itself, it's quite a complicated model. So if I walk you through a bit of the approach, we use the temporal information, so the progression of laboratory on the last 3 days of ICU. In an auto-encoder fashion, we extracted a version that can be combined with other data, and we combined it with the presence of a head scan and the service of admission. And we put a classifier on that to predict if it's a potential organ donors or not. And the comparison is the last data point, so the last laboratory value for that patient combined with the same information. We do not have the time progression, so we do have a bit less quantity of data, and we do not have the time evolution of the data. Same prediction, comparison of the model. So our main results, which are ROC curves on the left for the neural networks, on the right for the logistic regression model. And as you can see, both models perform quite impressively. The neural network did perform statistically better, but it's marginal, but it's still there. And most interesting, if we go in the subpopulation, the one that interested the most is the potential not referred, because it's the one that may resemble the most to a missed or potential organ donors, so someone that's not referred. We could say that our complex neural network did perform better than the logical. It's a sub-analysis, so it's hypothesized, it's generally hypothesized, but it's quite interesting. For those who prefer numbers, so it's almost the same thing. We do have a bit of more information. Sensitivity, specificity, our approach gave us a specific cutoff. In that cutoff, we do have the same performance of the models, but if I go back to one slide, sorry, you can see that the cutoff was around there. Depending on the cutoff that you choose, you could have better performance, depending, it's all a question of cutoff. Another element as a sub-analysis that we did that was quite interesting is for patients that died in the ICU, that our algorithm predicted as a potential organ donors. What happened to those patients? Are there false positive? What's the reason that our model predicted? So I took 7 of them. We have 11 in total. But first and foremost, we had one patient that was probably missed by the ODO death audit, sorry. which we do not see in the file a reason for not referral to CITADEL, and a reason for which the death audit did not flag him, but we did find one. So maybe even more sensitive in an approach. We had 3 patients with reason that could be controversial to not refer that patient. So chondrosarcoma in a young patient, a glioblastoma with a brain bleed, also in a young patient, and a neurodegenerative disease. All of them could have been referred to the ODO. And we had 3 patients that had brain bleed or pneumonia post-pneumonectomy. So basically that had neoplasia, but our system did not have any information about that state. The system could not have known that the patient had a cancer in the past, but it's quite frankly the only reason that the patient was not referred. We also did.
If I may, Nicolas, can you come back one slide? So just so everyone realize, the result you've seen in the last few slides are the worst case scenarios, because we did penalize ourselves. So we used the ODO death audit as the gold standard, and we assumed that it was a ground truth and it was perfect. But what Nicolas just showed you is that sometimes the model was probably still right. I mean, we would not call this an error by the model in real life. Would have been very comfortable, the model flagging this patient. And yet in our statistics, we considered these cases as being wrong by the model, which is not really true.
Thank you for the presentation. That's why I put that it's not truly a false positive. It's technically a true positive, but for statistics and to be rigorous in our approach, we did consider them as false positive, but yeah. So we did a bit of a prospective simulation. So the model has to be used in a continuous fashion. So we did simulate what if we had access to 8 hours before discharge, 24 hours and 48 hours before discharge, how would the model perform? And we can see that he retained quite a good predictive, good AUC, a good prediction. And in 48 hours before, seems to be a bit better with the neural network, but again, it's a secondary analysis. And we did an imperfect but still interesting external validation. So we used the coronary care unit, which is inside the hospital, but it's managed by a different clinician. It's a different population, and it's quite harder subpopulation because every referred patient is transferred to the ICU. So we only have the missed organ donor, well, not missed, but not referred organ donor throughout the years. So it's difficult, but it's still interesting to see how the algorithm perform in that setting. So in the out-of-the-box approach, we retain quite a high ORAP, so quite a good predictive capability, but not the best. But the second part is we asked ourselves what if we fine-tuned our network to the specifics of the coronary care unit. And we can see that there is a bit of improvement, even with only 9 not referred donors. We can see an improvement in the prediction. It's very small numbers of organ donors, so it's a process. It's how we could use it, but it's not convincing, and we'll still need to have an external proper validation and a continuous validation, but still quite interesting results and quite an interesting approach to fine-tune a model to the specifics, or here in a small unit, but can be to another hospital, to another setting. So what are the next steps? One of the most interesting steps that we're looking at, and one of the data scientists, Claude Kaufman, is looking at, is radiology, because we know having a head scan nowadays is quite frequent. So can we use that data of the head scan to help the model be in standalone, and how can that improve? So as you know, a catastrophic brain injury can look different thing, can be either diffuse ischemic, can be quite a large visible fashion. And if we try to differentiate between the potential organ donors and the not, there is a subpopulation that's quite easy to assess, but sometimes they are inside the rest, and you cannot, with a simple algorithm, flag them. But what Claude and his team are working on, which is quite interesting, is they automatically extract only the brainstem of the scans automatically, so no manual recognition, which is quite faster, to be honest. And on the brain stem, they trained a convoluted 3D network to assess the same output that we have. And the first result that we have are and that's only the imaging. It's not combined to the laboratory. It's only the imaging as a standalone. It's quite impressive. So we're looking at now combining the information to have multiple point of view and hopefully improve the model as a whole.
So for the clinicians here are those who know how to read these images. I don't know if you noticed, but it's contrast negative scan. So those are not angio scan. So we were able to classify neurologically deceased donors or potentially neurologically deceased donors only on contrast negative CT scan.
And what's also interesting is we have here are the same output than the first. So it's not only brain death, it's potential organ donor. So it's even harder because you can have someone who retains neurological function, but still has a brain damage that is important enough that he should be referred to an ODO. So it's even harder than only diagnosing brain death. And so future work, some of it is pending, some of it is future, but we have three ways three approaches that we need to improve. So first, of course, the model needs a bit of improvement. From what we got from our first analysis, we think the type of data is more important than quantity. So it's not training that on hundreds of thousands of patients that will improve, frankly, but more to add brain scan, to add somehow past medical history, mainly neoplasia. So if we could parse through past scan and past reports and past pathology report, we could flag some of the patients that have neoplasia and flag them out. Mechanical ventilation is something that's not digital in most of the hospital, but it's quite important for our subjects. So we're looking at way to add that in the model, but in a low EMR setting. It's going to be still used in a small hospital that doesn't have any medical recording. And we have, of course, the external validation, and we'll have to see first, do we use that as a pre-trained model? Do we use that with a fine-tune? There are problems with the confidentiality of data. Can we transfer a model? And do we transfer the data between hospitals? Do we transfer a model? So it's a whole subject to explore. And of course, we always keep in mind that if we want the algorithm to be used in a real world setting, it has to be used where that does matter. So small hospital with less resources in terms of personnel, so nobody has to fill a form for every patient. That won't be used if we use in that approach. And of course, as we said, the prospective validation for the acceptability, for the ethical and the legal standpoint of it, but also who to use. Do we use that on every patient, on a subset of patients? There's a lot of questions to be answered. And what's the acceptable false positive rate? Because we all know about alarm fatigue, but if a patient flag positive 8 times a day, they will just shut off the system and it won't use it. So we have to think about the implantability of that. So to answer the original question, can it be used? Probably, but it's quite an interesting but quite a challenging task. And of course, I did not do that alone. Of course, Dr. Chassé, Rima, Claude are participating, but almost all of CITADEL and some other are working on. Thank you for your attention. And of course, if you have questions, be pleased to hear them.
Oh, thank you. Thank you both for a very interesting presentation. It's definitely a complex study and probably deserves more attention. I'm quite sure it deserves a great deal more attention than we can give it in 20 minutes or so. I thank you for it. Are there any questions from the floor? Anybody here have anything to say? I see no raised hands.
Hans, I'll jump in.
Thanks, Matt.
Thanks, Nicolas. Thanks, Nicolas and Michaël. Always
Matt.
yeah, always great to hear from you guys. I might have missed it when you were during the presentation, but what were the time points that you were taking the data? When exactly were those points collected?
Yeah, so you did not miss it. I skipped a bit about it because for the respect of time. But the way we approached it is potential organ donors do have quite more frequent data points. So we wanted to have more data points because we use them. But if we do like 4 times a day, it may inform the system that the potential organ donors, you're predicting the frequency of laboratory and not the clinical pattern behind. So we did a midpoint. So we did 3 times a day. So basically 1 labs per nurse shift. And the way we approached it is we wanted to have the most informative signal over the nose. So we used the last 3 days of ICU stay. Meaning with our approach was last 3 days of ICU stay is where the clinical pattern is the most marked. So if the patient has to die, he will die, of course, in that time frame. If the patient has to improve and leave ICU, he will be improved in that time step. Of course, we do not know in a prospective fashion when the last 3 days will be, but to train the model, we wanted to have the more frank clinical pattern. So we did last 3 days of ICU, 3 labs a day. So for 72 hours would give us 9 time points for every laboratory.
Okay.
So if I may, so that was an interesting, very interesting finding, because Nicolas' initial model was extremely good, because what we realized, well, we know it on the floor, but we did not realize it on the data side, is that as soon as you flag a patient as a potential organ donor, then the frequency of labs change, because you start to activate some kind of protocol, and then you start to draw more and more and more blood. So we had to penalize the model. So the model is not aware of this thing, because then it was just learning that the patient had a lot of labs, and the model was not learning anything else. So we had to penalize the model. And second, what I want to emphasize is that we have to be careful what we take, the kind of data we take, because everybody who comes in the ICU is a potential organ donor. So if I go there with after cardiac surgery, I will be alive, hopefully, and as healthy as possible. So if I run this kind of model at time of admission, the model will say, yeah, sure, the kidneys are fine, the heart is fine, lactates are normal, patient is a potential organ donor. So we don't want the model to flag everybody as a potential organ donor. So you have to think carefully how you apply it, and when you apply it, so it's meaningful. So that's why towards the end of the ICU stay, it starts to make sense. And it's why when it's a big challenge when you go prospective, if you apply it at admission time, everybody will flag. So you need to apply the model at a time point that is clinically meaningful and that will be informative.
And yeah, and I think as you and we refine the model, it'll be interesting to see, because I would suspect that well, I'm curious if the potential donors had a length of stay that was different. And so then they had so it might be that their last 3 days were, say, day 5 of admission because they were so sick they were going to die early in their course, versus patients who were there for 2 weeks and were recovering. That was the last 3 days were day 14 after injury or something like that. So did you find that in your model?
It's not important, Matt, because it's longitudinal, so you don't know the future. So the way Nicolas trained it, and Nicolas, you can complete, is that we don't look in the future, right? You take what you have and you make a prediction, and then you move your time window forward, and you look and you move forward, and so on. So, and we did not look. The model was penalized from the past. So we only kept 3 days, because if we start adding this kind of information, then we could bias the model big time. So we fixed the time window to a moving 3 days time window. So we were extremely aggressive in how we penalized the model. So because we want this to be clinically useful, so we have to be careful not to give too much information.
One of the other thing is, as you may have noticed, we did not input age or gender or something like that, because it's not a good reason to exclude an organ donors. We do that clinically. So age, for example, would have biased the model toward younger people, but we do not want to exclude older people just because of their age. So we had to think what is important for the model and what would bias to the clinical approach and not to the clinical pattern.
The clinical pattern is simple. What is an organ donor? Forget the healthy brain population, but among a brain injured patient is a patient that is brain injured and dies with functioning organs. So this is the pattern we found. So head CT, serious admission with some organs that are still functional that die. So this is a kind of a patient that the model will flag.
Okay, thank you. Katja.
Thank you. Thank you for your presentations. I mean, machine learning is just such an exciting and very, very promising field in our type of research. I'm a researcher at McGill University. I just have a quick question. My research focuses on living donors. So I was just wondering, is it at all possible, or it's a bit of a stretch to even consider something like this when it comes to streamlining things in the assessment, in the workup of living donors?
It's quite an interesting question. I will answer it on this. The reason is the response is probably yes, but you'll need to have a data set with an output that you want to predict. And the way I see machine learning is it's a tool that can leverage different type of data. So usually you'll have, in the past with the logical regression, you'll do that with the data point of laboratories. But with machine learning, you can use temporal values, you can use imaging. So to answer your question, if in your workup, when you approach a patient, you combine information from the liver biopsy, for example, report, combined with the data, combined with the evolution, you could combine that with the machine learning approach, and it would be totally an approach that would be functioning. You'll need to have a data set to train the model on. You need to have, unfortunately, a lot of data, but if you have those data with the outcome, yes.
Mm-hmm.
So this model would not be appropriate at all because you don't have this kind of flat values and so on. But clearly, you could take all your living donors and the one you accepted and rejected and train a model from that. But yeah.
David Hartel, hello.
Oh, hello, Hans. Nice to see you and nice to see everybody. First of all, just thank you, Michaël and Nicolas, for a very interesting presentation. This is a project that I've been really excited about over the last couple of years. And honestly, I think I've told dozens and dozens of people about this project because anytime I want to tell them something cool about where we're going and AI and organ donation, I always talk about this project. And so it's great to hear more about it. I guess one of the things that I think would be helpful for me just to understand when I'm telling everyone about how cool this project is the piece about prediction. And maybe this is where I'm getting it wrong about the study. So when we're predicting and listening to your presentation, are we predicting, just to be clear, are we predicting like who is and who is not a potential donor? So, you know, we only flag them in the system as soon as they are identified as a potential donor. And it's a very sort of black and white, it either they are or they aren't. Or is there a certain sense of like predicting that somebody will become a potential organ donor? So I guess my question is, how far back are we in the system of saying, okay, well, there's a pretty good chance that this person in this room will then become an organ donor, and we can predict and start managing, you know, moving care around or making other decisions based on, you know, the model is predicting this person has an 80% chance of becoming a potential organ donor? Or are we training the model to only flag people that have been, you know, they are potential donors?
So the way it works is we did not have timing of becoming a potential organ donors. So the patient, his outcome has died on, mostly, if not all of them died, was a potential organ donor. So we did not have a moment of becoming in the training of the first part. But in the second part, when we will be a prospective validation, that's something that we will be looking at, is when, at what moment in a patient course, clinical course, does the flag goes up and he becomes a potential organ donor. But the way we used it is as a screening model to detect maybe at a distance for a patient, this patient should be investigate, maybe referred, and approach in that fashion, and for maybe a clinician that did not think about it, or that it was not in his plan of care, but that's the approach we used. So there were no time point at that moment he became one.
Nicolas, I think I think we need to clarify something here. Two things. First, David, it's not yes or no. It's a probability, and then we selected a cutoff. Okay, so we selected a cutoff. So at what probability of being an organ donor you will reach a sensitivity of, we use 90. But the cutoff could be anywhere, but we could just not use a cutoff, and we could use a heat map, for example, where each patient would have a color from green to red or whatever, and the darker, the more chances, or just a number. So in the tables, in Nicolas' table, Nicolas, you can maybe show your screen. For each patient we showed, you do see the probability of being an organ donor according to the model. So the output is not yes, no, the output is really a probability, and then we had to fix, you just passed it, and then we had to fix the threshold. Second point, Nicolas, just the table, yes, here. So you see the number you see here in the first two columns is the probability of. So you have the neural network, and then you have the logistic model. So again, we have some calibration issues, but the model will tell you what are the odds. Okay. Second is David, in the prospective validation, and Nicolas, I don't, you maybe you skip this part. We do feed the model with prospective data, so as it comes in, and then we make a prediction at, so here is 48 hours before that, 24 hours before that, 8 hours, and so on. So, and then it gives you a number. So in prospectively, that's what we'll see. But what we expect, and that's what we saw in our simulation, is initially the number of potential organ donor is very high, because you have a lot of patients that are kind of healthy. Well, it can change. You can enter the unit with very sick and end up healthy, and vice versa. But it will, each time you have a new feed of data, the model, it updates itself and gives you a new number. So here, this is your question, David, I think. So at 48 hours, this is our accuracy, 24/8, and at time of death.
Yeah, that's very helpful. Thank you.
So we did use a threshold. I don't think in clinic it's very useful. I think it might be even more useful not to have a threshold, in fact, and just see a number like this patient is 80%, this patient is 70%, and then it would probably inform the clinician. But what do you do with a 12 or a 5? Still potential. So that's why we probably need to think about something else.
There is a question in the chat from Patricia Gongle. Is the model equally accurate for all sexes and genders?
The model was not exposed at all to this information for several reasons. Because in theory, because the problem is, so this is a tricky one. Problem is, if you feed the model with gender information, you could capture a bias. We don't know if it's true. We don't know at all if there was a bias in referral and so on. But remember, this kind of model learns something. Okay, so they learn from what they see. So if we expose sex and by accident we have a bias in our data set, then the model we train would be biased. So what we did is we normalized everything. So all patients are equal in their chances of having the labs, because even the frequency of the labs is somewhat normalized. So in theory, it should not change anything. Now, the next question is, should we stratify and test the accuracy based on sex? The short answer is yes, but if we do that at this stage with a small number of patients, we could end up with different accuracies that are just due to chance at all. Okay, so we restricted a lot of our subgroup analysis. In fact, we did not do any subgroup analysis by race, gender, and so on. We only focus on a type of organ donor, and that's it. And to look at these subgroups, it will require much more data to do it correctly. Because then the other problem, guys, is think about it. Suppose that we find a bias and we see that the model is very bad with women and very good in male. We won't be able to know why, because we won't have the data. It might be just bad luck, but it could be several other reasons. And then we raise all these questions about what are the clinicians doing right now? Are they biased in their way of referring the donors and so on? And it's a completely different issue. So it's on the radar for when we have data, prospective data, what we'll do. And it's in the next project, we prospectively collect the required information to measure that. You follow me? So you can't do it properly retrospectively, but if you plan for it prospectively, then you can measure it correctly and know what's going on if there is an issue.
Yeah, Katie Bain asks if it's the same for ethnicity and race.
The model is completely agnostic to all patients' characteristics. So we did not include medical history, region, postal code, and all these kind of socioeconomic biases. The model is agnostic to that for now. We only use the labs and the service of admission and CT scan. So if there's a bias, so for example, some race don't have a CT scan or have less labs or something like that, then it could introduce a bias, but it would have to be related to the objective data we are using.
And to add on, the criteria outcome was agnostic to sex. It was quite clear criteria, quite objective criteria of potential organ donors that should not have been too much biased.
But I mean, it's still possible that the clinical practice changes the way you measure your labs and imaging and so on. It's possible, but it's true in all fields. And to measure that, you can't do it the way we build the data. It was impossible to capture. So that's why we need to do it prospectively. So David question here. So the next step is we do have several projects ongoing, one of which is interviews with a lot of people like stakeholders, patients, healthcare workers, patient partners, religion, professions, and so on, to first explore qualitatively what are the views and perceptions, but also the dead angles, the risk, and so on. We have also a prospective study almost ready to start, where we will collect prospectively the accuracy of the model, but also collecting prospectively all the different sources of bias that we could miss retrospectively. So then when we stratify, we'll be able to compare and check for all those bias. So those are some examples of what's next. And there are a lot of technological studies too, because you need to optimize it. You need to make sure that you don't have to hire data scientists to pre-process the data to use it. You have to use data as it comes in, and a lot of other challenges like this.
Okay, it's time. In fact, we're a minute over. Merci, Dr. Chassé and Sauthier. I thank you very much for bringing such progressive work to the industry. I don't know, whatever we call ourselves, and CDTRP for providing the platform on which it can be presented. It was most interesting hour and deserved more. Thank you all. Have a good day.